Now we would like to introduce our last speaker for the symposium, Dr. Mary Margaret Sharpucci. She is an assistant professor and chair of the Department of Healthcare Administration in the Parkinson School of Health Sciences and Public Health at Loyola University. As a healthcare analyst with over 35 years of experience, her career has included senior positions with Blue Cross Blue Shield Association and Loyola University Health System. She currently serves on the board of directors of a privately held healthcare startup company, is a task force appointee of Illinois Governor Pritzker, working on disability issues, and was recently invited to join the board of trustees of Aurora University. So welcome, Mary Margaret.
Well, thank you for the opportunity to be here with you today. And we're going to start here, $20 billion. And what this refers to is venture capital dollars, supporting new technology, supporting new startups. And venture capital firms have been around a long time, long history of providing funding to startups with potential, but nowhere is this more true today than in healthcare. So everything, wearable devices, mobile health apps, telehealth, and so on. So that $20 billion is just 2020 alone. That's 1 year represented. And the $20 billion represents just the 150 startups judged to have the best market potential out of thousands of contenders. And out of all those contenders, about 98% will fail. So the big question is, where are the capital, or where are the venture capitalists funding? And the big answers are clinical intelligence, screening and diagnostics, telehealth platforms. And that's not a surprise to anyone given our past year. But I want to point out just a couple small companies that garnered some funds. And one is called IntelliCare. $45 million investment went into it. And what it's about is workforce management in post-acute care. And we're all familiar with the staffing challenges that are associated with post-acute care and its relationship to quality. And to see that $45 million is being invested in a startup to look at this very issue. Then there's Kaizen Health, over $20 million invested here, and they're focused on creating a national network of transportation to and from appointments. And we also know what a challenge that is and its effect when you don't have transportation, its effect on quality care. And so these initiatives, they speak to care, they speak to solving a problem, and they speak to cura personalis. So if I were to ask healthcare CEOs, what is keeping you up at night? I'm pretty sure this would not be their answer. So augmented reality, chatbot, and voice search probably wouldn't jump off their tongue. But if I changed the question, what's keeping you up at night in the context of technology, I think it would be the answer, because healthcare leaders know that these initiatives are changing the face of business as we know it and as we're experiencing it. And here's a great example. This is Truveta, and you might, if you're associated with Loyola, you might have heard about this, because there's been a major announcement just recently. Dozens of health systems with millions of patients have banded together to form Truveta, and Trinity is one. And we're in good company in that. It's a data-driven collaborative, and it's all about scale. So it's billions of clinical data points all put together in a single search. It's about precision medicine. It's about population health. It opens up a whole new world. And this is a very different way for a health system leader to serve their local community. And it's all made possible with technology. So we have pools of capital dollars, lots of them. We have ideas, lots of them. And we said only 2% of these ventures overall are going to succeed. So what defines success? Does being capital funded, does that make you successful? Or does it only come once your product is to market? or when the market proliferates? Well, I'd like to say that it's successful if it brings meaningful change to the end user. Now, everyone's not going to agree with this, particularly if you're the investor. You are looking for that market proliferation and not so much the meaningful change. But let's look at an example. And the question here is, who is the customer? This is a standing wheelchair, and it was developed during time when I was working with Shirley Ryan Ability Lab, and they are one of the several patent holders and developers of this mechanical technology. If we talk about quality of life, this is meaningful change. You can reach for something in your cabinet. You could go to a cocktail party and look people in the eye. Health outcomes change, effects on pressure sores, contractures, but it's considered an assistive device, not a medical necessity. So insurers would not pay for it, despite the meaningful change that it could bring to an individual. Insurers would not pay for it. Now, things have progressed somewhat since then, but it's still a very difficult proposition to get this paid for. So let's go back to my question, what is success? Yes, there was meaningful change, but there was not really a payment mechanism. There was not market proliferation, and there was not capital funding into it. But there was meaningful change. And we cannot underestimate the payment piece of it, the mechanism. Let's just look at telehealth for a moment, because it was languishing out there with these arcane payment and revenue mechanisms. And then COVID came along, and it was like a light switch flipped. CMS relaxed the rules. The big payers followed. Telehealth is launched in literally days. It's a regulatory and reimbursement environment turned on a dime. It's usually not like that. I think we all know that, but we've shown that it can be. Now, we could come up with a lot of examples, I think, of a successful product because it met numbers 1 through 4, but it didn't meet 5. And I'll just use cancer therapeutics as an example. We've got several out there that add a month of survival, 6 weeks of survival, and it's hailed as a breakthrough. As an absolute breakthrough, and it brings in more capital funds. Stocks go through the roof, but we have to ask the question: are those weeks meaningful change? Now compare that to something like palliative care, which a lot of research out there to show it does bring meaningful change, but we don't have capital funding for it. The reimbursement is spotty at best. There's no market force behind it. And just like our standing wheelchair, it's important to the patient, it's meaningful, but not so much the investor, the funder, the payer. So now let's take a look at some examples where all the criteria are met. We've gone from capital funded to meaningful change. So here we have the point of care MRI. It is estimated that worldwide we have about 4 billion people without access to medical imaging. So there was an entrepreneur, his name is Jonathan Rothberg. And so what he did was he invites a group of tech innovators, this diverse set of people. He invites them on his boat in Miami. And he takes them out to sea, and then he says, I control the captain here, and so I control when we go back. And I've got a question for you, and we're not going back till you give me the answer I want to hear. And so he said, how can you make an MRI that can be built for less than $10,000? It won't interact with metal objects. You don't need its own room for it, and it would be portable. And if he could get them to commit to answering this question, he was going to bring them back to shore. So he was very persuasive, obviously. And so, excuse me, his group of people that he brought together, this is roughly 2017. At that point in time, we're at about 10 million-fold improvement in computing power since the MRI originally launched, which was 40 years previous in 1977. So they had a lot to work with there. And so this is what they came up with, the point of care MRI. It plugs into a wall outlet. It's controlled by a tablet like an iPad, 20 times lower cost, 35 times lower power, or runs on 35%, 35 times lower power, 10 times lower weight than a conventional MRI. So it is becoming available to those 4 billion people without access to medical imaging. And that is meaningful change. And here's another example, ultrasound scanner, just like the idea of putting a camera on a semiconductor chip made photography available to every one of us, everyone with a cell phone. This is what the ultrasound scanner is doing. It's doing the same thing worldwide. It connects to an iPhone app, costs $2,000 versus $200. And the Bill and Melinda Gates Foundation are doing great work in making it available to countries who can't pay for it, and countries who can, it is being sold for markup. Meaningful change. And here's another one. We don't need to say much about this here because we just lived through this. Speeding drugs through artificial intelligence. The COVID vaccine, it had capital funds galore, brought to market in record time. It's got a payment mechanism, market proliferation, and meaningful change, with AI playing a crucial role. So technology, it can be successful. It doesn't mean care happens. So today's symposium is about care. It's about cura personalis. How do we tie the two together? Well, when we talk about what matters in healthcare, when we talk about what our future is in healthcare, these are the phrases we hear, and we hear them a lot. Whole person care. Well-being is going to replace treatment. Customer is at the center. Health versus treatment. So are we being true to these principles? Is technology being true to these principles? Because we see a lot of this. The robot will see you now. We're fascinated by the technological achievements, but is it what patients want? And Dr. Houston addressed this earlier in her discussion of robotics and where that fits. And there's a lot of wisdom in this thought here from Rowan Chapman at Manor. And he says, don't get lost in the hype. All these things, artificial intelligence, machine learning, voice search, they're tools. Focus on the problems. And then take a really careful look at what's possible technologically. What can you do about the problem that you couldn't do before? And to the extent that our robot we just saw solves a problem and allows us to do something we couldn't do before, then it's a good thing. And here's an example. During COVID, we had robots performing clinician functions. They were doing things that saved precious PPE when it wasn't available. So there's a robot tool, there's a tool that solved a problem. But a tool that solves a problem, that phrase, does not necessarily describe all emerging technology. Now here's a good example. This is the health check chair, and it made a huge splash back in 2013. So it came out to a lot of attention, and it's like, wow, look at this thing and all that it could do. And it seemingly did everything in the way of home monitoring. It took vital signs, weight, monitored body motion. You could store it all on cloud. It's all set up to do video conferencing with your provider. So, it was doing everything. Now, I won't comment on the aesthetics of having this chair in your living room, but it was not so successful here. The technology worked. It worked fine. The care did not. The technology was all there, but the care could not be found. And so it was a total bust. It went out of business. It was one of the 98% of the failures. So we have to go back to our question, what problem are we solving? And I think there's a lot to take away from this statement too. The innovation we truly need. It's not a shiny new piece of technology. It's not a quick fix. It's new and different ways of thinking about what healthcare already does. And so this makes me think of chronic care innovations because they are the recipient of many of those $20 billion in startup funds I was talking about earlier. We have 4 out of 10 adults in the US with a chronic condition, 6 out of 10 with 2 or more chronic conditions. And much of the attention, aside from developing the technology, aside from developing the apps, goes into patient engagement for chronic care management, and which is getting people to use the technology and getting people engaged in the apps and applying it to their own situation and their own care needs. And then it makes me think of this question of why do we need so much in the way of patient engagement strategies? In my work with Manner, that's where a lot of our attention is going, is these patient engagement strategies. And if we compare to other industries, Airbnb, Uber, DoorDash, they don't focus on client engagement strategies. People use their services because they bring value. And the same applies to healthcare. The technology has to bring value. And it makes me think too of the language we use, because we say digital health. We focus a lot on that, digital health. It's really health. Health is our focus. And if you, again, compare to other industries, when you do your banking, you don't say, I'm going to do my digital banking. We say banking. It's all wrapped up into the experience and to the value. And I'm going to go back to this question of asking our healthcare CEOs, what keeps you up at night? And I think this is more aligned with what the real answer is. At least a lot of what would keep our CEOs up at night. And if you notice, the word care is in every one of them, almost. Transitions in care, care coordination, complex care management, improving outcomes of care, lowering cost of care, lowering readmissions. And again, so many of those $20 billion in startup funds, these are the problems they're trying to solve from many different angles. So let's take a look. Who is really winning these venture capital funds? Well, if we look at the top 2, seamless patient data flow, digital monitoring, that's not a surprise because interoperability is on everybody's lips. It's about what we're trying to do with patient data, digital monitoring, chronic care, that's those 2 are highly tied. But then look at the other 4. Telemedicine, of course, because of the year, again, that we've just had. But I like to focus on the 3, home dialysis, end-of-life care, palliative care. I think that's a telling sign of where the dollars are going, because this is a win for Cura Personalis. Looking at where the needs are, home dialysis in the home, end-of-life care, palliative care. And then at the very same time, we have the Walmarts and the Amazons of the world taking on primary care in a big way, very big way. So they, in particular, Walmart is showing us that these major advances are less and less coming from or being driven from inside our delivery system, but increasingly from innovators outside of it. And so enter Walmart Health. They launched the first one in 2019, so very recently. The first one was set up in Georgia, and by the end of 2021, by the end of this year, they will have 22 Walmart Healths open, which are their Walmart super centers, including 2, which are currently operating in Chicago. So those are open already. And Walmart Health offers a whole array of services, key services, labs, dental, nutrition, insurance enrollment. They have advisors there that will get you enrolled into, will work with you with your ACA options. They have veterinary care too. So they have the gamut, everything you could want in that Walmart Health. And it's a Walmart trademark. It's below market rate. And that's, I mean, That's what they are about. And it's transparent pricing. The patient is told the estimated cost when the appointment is booked. Whether you're insured or not, it's the same pricing. How beautiful is that? Primary care visit, $40. Dental cleaning, $45. Therapist, $1 a minute. Now, how are they doing it? It's their same retail model: scale, volume, supplier partnerships, all very AI-based. So very tech-based. And this is revolutionary for healthcare. But their second feature, which I think is interesting, is the geospatial, the density mapping. They are looking at unmet needs in their various communities. So they're doing density mapping of Medicaid births, teen births, low birth weight, diabetes, and on, and making an attempt to get the right services in the right places. And if you think about it, you have about 150 million people walking through Walmart every day. They've got over 5,000 stores nationwide. And their goal, the business goal, is to have a Walmart Health in every one of them. And they're moving into home services now. So this is technology turning the way we do business on its head. And let's look at another example here. This is One Medical. And this is another example of a new model of technology-based primary care. So again, it's applying machine learning, it's applying AI to a broken system. And so what One Medical did was say, hey, we've got these sky-high costs, we've got convoluted business models, high friction workflows. We can change this with AI. And so that's what they set out to do. Now they are going to be at the other end of the spectrum from Walmart. They're a members only concierge model. And the cost is $199 membership fee each year. And they do have a small direct to consumer piece of the business, but their major business is employers. So the consumer himself is not paying the $199. That's generally coming from the employer. And so that's their primary market. And their growth, if you look at the cities that are listed on the right-hand side of the slide, last year, I was invited to do this talk for Palmer, which as Lorna talked about this morning, we had to cancel that. And so I had this slide prepared, and it had less than half of those cities listed. So 1 year later, the slide almost doubles. And in this time frame, they are now valued at $2 billion. They had an IPO, so they went public with another $245 million invested in them, and got more capital funds of another 350, another 280. So they still have a lot to prove, but it's a very different model. And will it be successful? So the employer push is one of the differences. They have about 7,000 employer clients at this time. Big ones: Google, Uber, Adobe. None of those will surprise you because they're all high tech. And so this would be the very thing high tech companies gravitate to. But they've got the traditional ones in there too: McDonald's, Boeing. And those type of companies are growing their base. Now, again, going back to my slide from last year, there were 4,000 employers that were in their client base. This is now at 7,000. So machine learning algorithms create the patient experience. That's what One Medical is about. So it's constant learning, and it's this continual improvement. Their top features: more time with the patient, same day, on-time appointments. And that's their top thing that they market. So more time with the doctor or more time with the patient. Everything's based on mobile apps, telehealth. All the providers are salaried, so there's no quotas, which leads to having longer appointments and discussions The patients are much happier. The doctors, the nurse practitioners, everyone's much happier. And the other big thing about this is that's all well and good, but also the streamlining of claims and payment processing. That's a huge piece of what they do. It's a huge piece of their AI. So they are chipping away at that $800 billion we pay in administrative costs each year. So they're really lowering that piece down, which is part of their success model. So all of this AI, all of this machine learning, and all those other acronyms I showed you at the beginning, it all leads to these longer appointments. Getting to know your provider better leads to less diagnostic costs because you have a better understanding of the patient, and leads to less ER visits. So in some cases, they have been showing, some of their employers have been showing over 40% reduction in ER costs, which is pretty phenomenal. So again, they still have something to prove here, but it shows you the connection we can make between care and technology. And overall, the problems are messy and sometimes hard to decipher. And yet our technology solutions, we tend to want them nice and sleek. But do they get the job done if we put this sleek answer to this messy problem? And so then I say, well, we got to go back to the basic question. And the basic question here is, what business are we in? Oh, we're in the business of keeping people well, helping them when they're sick, and this is care. And this is cura personalis. So how can we bridge care and technology? And I think the answer is giving people what they want. And what do they want? And a seamless experience, yes. Transparent pricing, lower cost, decreased disparities, a frictionless system, a predictable system, and really human touch. And this goes back to what Dr. Houston talked about this morning. So if we can create this bridge between technology and care, wow, that's audacious. That would be audacious. And so thank you. Be happy to answer any questions that you might have.
Thank you so much, Dr. Sharpucci. That was a wonderful presentation. Dr. O'Connor, are there some questions?
Yes, and yes, thank you again. And I was making notes, Dr. Sharpucci, and I said she just actually brought us back full circle from a lot of the initial questions that people talked about regarding equity, accessibility, and the costs. And so some of the questions that came up are, what can nurses in particular do to help solve this problem? Where should we be? Because a lot of times nurses and in particular, but healthcare providers seem to not be at the table when these discussions are happening. And I really appreciate your healthcare administration perspective on this.
I think, the answer to that, how can you be involved in the development of the technology and the deployment and all of those pieces? I think you are to, and there's so many examples of it here as you present your research, and because that's the beginning pieces of it. And I think that tells us where we need to go. But making that research available to those tech innovators, to those places like Matter, where we have these hubs going on, and I think I keep bringing up Matter, and it's because they're a good example and a local example of a massive hub of healthcare technology going on. And the more clinicians that can be involved with tech innovators, the better the partnerships. And I think that's it, is making that partnership. Can I give just an example here? Because this is great. So I don't know how many of you know of SwipeSense. And so that SwipeSense is a company that came out of Matter, and it was acquired last year. And so that's that's the thing you're striving for, is to be acquired. And so that's a big success factor. Swipe Sense, the original research that came out of Swipe Sense came out of Niehoff Nursing. And so this was several years ago, and several of us worked on it, myself included. It was one of the leaders of that was Dr. Ida Andrewich, and many of our students were involved, many of my healthcare administration students, many nursing students. So all that was a very team effort of getting that up and moving in its very, very, embryonic stages. But look where it went. But nursing needs to stay in that partnership and stay with those tech innovators all the way through this process, and not give it up too early, because the research kind of drifted away from Niehoff and went off into the tech world, but it shouldn't have. It should have stayed as a partnership and in a parallel.
Thank you. I do have a couple more questions, and maybe some of these questions can also, the other panelists may have something to say as well. But what do you think about Walmart cutting out registered nurses out of primary care clinics? They employ advanced practice registered nurses, medical assistants, MDs, DOs, but nurses are not there. RNs, registered nurses, I should say. So if you, from a healthcare administration standpoint, you probably see this a lot in primary care where the registered nurse is not there.
And always, looked at from a cost perspective. And so I see that, and I'm not saying I agree with that at all of it. I do see it, and I understand why it's happening. Again, I'm not involved with Walmart enough to know what went into the decision making there, but I think the answer is similar in that, we have to have nurses at the table. We have to have nurses in leadership roles in Walmart, because they are now a healthcare company. And so I know when I say to my students in healthcare administration that I could see a future for you in Walmart, they look at me like, oh my God, no. And the feeling might be similar, I don't know, among nurses, but really we have to look at it and say, and I mean leadership roles. So I mean leadership roles in Walmart Health. Are there nurses at that leadership table? And the answer, I do not know, but there should be.
And so in all of this discussion, thank you very much. And I'll just interject here, but this is something in our curriculum in the undergraduate program that we really, I think there's a gap in discussion about healthcare policy, advocacy. So that probably also needs to be an important thing to include. The other question I have here is someone who is a palliative care provider and wondering if the trend towards innovation may actually alienate people when it comes to having those difficult conversations. And maybe this is also something that Dr. Houston, you might, and Carol and others may be able to talk about. Maybe Dr. Houston, this sounds like it might be, and even Dr. Kostovic, something around your area.
Yeah, Georgia, I just really enjoyed that presentation, and my mind is kind of spinning, and I'm just struck by this idea that I do think a really critical part of our socialization is this idea that all nurses are leaders. And nurses certainly, because year after year, we're identified as the most ethical of healthcare providers. But when you look at tools that look at influence, at prestige, nurses don't do so well. And I think that we as a profession have been invisible in far too many situations. And that media training, that a part of basic undergraduate nursing education is empowering nurses with this idea that they can and have a responsibility to be leaders in the healthcare system. Therefore, they have to learn how to brand themselves. They have to learn how to be professionally involved, to network, to form these interprofessional teams, and to just really look at what it is that we want our image to be, so that when people think about nursing, not only do they think about capable, qualified, hands-on care providers, but they see people who have this intimate knowledge of the workings of the healthcare system, who really understand patients and are best able to advocate for the clients that they serve, but also that they have the political change agent and leadership skills to be able to do that. It is kind of my mantra. So thank you for asking.
Dr. Kosovic, you're showing yourself, so I'm wondering if you have a thought.
Well, as far as having patients in palliative care, I can see where not just palliative care, but in other, across the continuum of care, the technology can be intimidating and can make patients afraid to want to communicate with their provider. And I think this is where nursing presence comes in. The nurse has to be taught and given opportunities as students to practice those communication skills and to reach out and connect with their patients, so that the patients know that there is someone there who is a real person, even behind the technology, that can address their needs.
Thank you. And I'll just read a couple of more comments before we're done, because I think it kind of ties all of this together. But points well taken. As healthcare providers, we need to offer more prevention. That is primary care at its best. We have been driven to spend less time with people when the opposite is what is needed. We need more time with patients and not less. And the final comment, palliative care, not only hospice care, must be a paid service by Medicare to be recognized as an option for families of ill patients. Nurses can push for this. So again, you know, for all the nurses and our nursing students out there, you know, you're going to be the leaders of the future. So thank you all very much. And I'll throw it back up to Karen here.
Oh, thank you again. I think we're so fortunate to have such wonderful presenters for our symposium.